Welcome everyone to the latest in our monthly series of bioethics webinars. My name is Dr. Sean Philpott-Jones, and I am the Director of the Bioethics Program of Clarkson University and the Icahn School of Medicine at Mount Sinai. Before we begin, I would just like to take a couple of moments to run over some basic housekeeping and webinar protocol items. First, in order to ensure proper audio, please make sure that you've turned up the volume on your computer speakers. If you are listening to this presentation by phone, please mute your telephone line so that others on the phone line do not hear any background noise or disturbance. If you experience technical difficulties at any time during the webinar, please call area code 518-631-9861 and someone will try to help you. You are welcome to ask questions anytime during the presentation using the text box on the lower left-hand side of the screen. It is likely, however, that these questions will be held into the question and answer session at the end of the presentation. If we run out of time before all of the questions have been answered, we will provide the speaker with an email list of queries for follow-up. Finally, this webinar is being recorded. If you or a colleague would like to see the webcast again, it will be archived and made available for you to watch on demand. Now that those minor housekeeping items are out of the way, it is my great pleasure to introduce my colleague and friend, Dr. Abraham or Abe Schwab. A philosopher by training, Abe Schwab is an adjunct faculty member in the bioethics program, but his primary appointment is at Indiana University, Purdue University, Fort Wayne, or IPFW, where he is an associate professor of philosophy. His research focuses primarily on biomedical ethics, and he is particularly interested in conflicts of interest in the medical community. In addition to his academic position, he co-directs IPFW's gerontology program, is a member of the Ethics Committee of Lutheran Hospital, serves on the Institutional Review Board for Lutheran Health Network, chairs the Allen County Ethics Commission. Finally, he writes a monthly column for NIPR, Fort Wayne's National Public Radio affiliate, where he focuses on such issues as end-of-life choices, the Affordable Care Act, and other bioethical and health policy issues. Professor Schwab will be speaking on professionalism. Specifically, his presentation is entitled, "What Does It Mean to be a Professional in Medicine and Bioethics?" Professor Schwab, please hit the talk button and the floor is yours.
Thanks, Sean. Thanks for everybody who's joined in today. This is a presentation that's a version of something that I presented a few years ago that I've continued to work on. But it actually is what led me to have my interest in conflicts of interest, as Sean mentioned, because it deals with the responsibilities or the obligations that professionals have. And so I wanted to sort of take a few minutes today to talk about what it means to be a professional. So when we say that physicians and other medical practitioners and bioethicists or clinical healthcare consultants are professionals, what is it that we are, what is it that we mean by that? What are we talking about? So here's a look at the plan for today. First, I'm going to spend a fair bit of time trying to define professionalism, because if we're going to talk about what it means to be a professional or that we should be professionals, we should know what that concept refers to. And then I'm going to try and use that definition to help us distinguish professionals from non-professionals. That is, how do we draw the demarcation so we know when we're talking about somebody who counts as a professional and somebody who does not. And then I'm going to take a look at a few codes of ethics. I'm going to spend a little bit more time on the ASBH Code of Ethics, in part because it provides a bit more meat because it's so new. It's a relatively new code of ethics. But then I'm also going to take some time to look at the AMA and the ANA Code of Ethics to sort of give us a taste of how well we're doing at defining these professions and their responsibilities. Okay, so defining professionalism. There are basically two different ways that we can categorize approaches to trying to define professionalism. It's not a new topic to do to try and define professionalism, and the older more historical attempts to define professionalism have followed what I call a substantive approach. And we'll detail those in a second. But there's some more recent attempts, and attempts that I tend to favor, that try and follow a formal approach. And I'll define those terms a little more as we move forward here. So I'm going to first talk about substantive approaches. There's a nice quote from Greenwood in which he sort of is analyzing what it means to be a profession in the late 50s, and, you know, succinctly put, all professions seem to possess systematic theory, authority, community sanction, ethical codes, and a culture. And so you can see why I'm calling this a substantive approach, because he is giving us a very clear set of criteria that something has to meet in order to be a profession. That is, there are boxes to check, and if they cannot check all of those boxes, then they're not going to count as a profession. And so this is one way to try and identify professionalism. And so we look, and so if we're distinguishing professionals from non-professionals, we can look and we can say, does it meet all of these criteria? And if it does, then we can say, okay, well, that counts. And if it doesn't, then it's not going to count as a profession. Now, a fair criticism might be, okay, a few things have changed in the last 60 years. But Baha'i in 2012 echoes Greenwood's approach, but only makes a few alterations. So rather than talk about systematic theory, she refers to expert knowledge. Rather than talking about authority, she talks about independent judgments, community sanction, and trust, which are almost equivalent in their discussions. And then finally, rather than talk about codes of ethics, she talks about licensing and disciplinary action. And this is a substantial distinction, because codes of ethics tend to be something that is defined almost entirely by the profession, whereas licensing tends to be more of a social contract kind of relationship. And so that's a fair breach between Baha'i and Greenwood in terms of what they're talking about constitutes the criteria for a profession. But they share, and this is what I want to emphasize, they share an approach in which they provide us with these check boxes. We're talking about a particular occupation. Is this particular occupation a profession? Only if it has all of these criteria. There are a couple of problems that these substantive approaches have to deal with, and one of them is a conceptual problem. And so what I mean by that is that there's a problem with the very way in which these approaches try and solve or answer the question, what counts as a profession? And that is that they beg the question. So what it means to beg the question is to assume the answer to the question that you're asking. So the question that we're asking is, right, what does it mean to be a profession? What does it mean to count one's occupation as one of the professions? And for the substantive approaches, the way that they go about this is they look at occupations that are considered professions and sort of glean out these substantive criteria. So Greenwood's piece spends a lot of time looking at various professions that exist and then glean out the criteria from those professions. Baha'i does the same thing, talking about how things have changed, but how there are still these criteria we can identify within the existing profession. And so when I say that this begs the question, what I'm saying is that there's this kind of circular logic behind identifying professions. And so one way to characterize it is like this. How do we know the criteria for a profession, right? That's what we're trying to look at. And their answer is, well, we look to medicine, law, and engineering. These are sort of, well, medicine and law are the classics in engineering for the last more than 100 years. These are what we do. So we look at these prototypes of professions, and then we glean out the criteria that then would help us identify other professions. But then we might reasonably ask, well, how do we know that medicine, law, and engineering are professions? Well, they meet the criteria, right? We're just counting them as professions. And so then we can see how this sort of assumes the answer to the very question we're asking. They're assuming medicine and law and engineering count as professions, and so then accordingly, then they use those to glean the criteria. Now, from a philosophical perspective, as Professor Philpott mentioned, I'm a philosopher by training. Begging the question is a certain kind of conceptual problem that would be devastating, but other people might be less concerned about that. That is, okay, so it begs the question, but does that create any more other issues, right? Is it just a conceptual critique, or is there more to it? And there actually is, because this conceptual problem then leads us to a couple of practical problems with a substantive approach to defining professions. One is, how is it going to address professions over time. So in 1957, Greenwood does a substantive approach, and in 2012, Baha'i does again. In those intervening years, in the 55 years in between, medicine actually changed quite a bit. And specifically, I just want to focus on financial reimbursements in medicine. So the way that medicine has become tied to industry has led to a series of concerns about whether or not medicine is, fulfilling the same role that it was before. And this is expressed pretty clearly by Catherine DeAngelis in JAMA. As business has become very much entwined with the patient-physician relationship, sometimes it may be difficult for physicians to remember to whom they have primary allegiance. And so what this means is that because now physicians are in a position where there's supposed to be a primary focus on the patient, but there are these distractions from that focus that arise from the reimbursement schemes that are used in medicine, then we could reasonably ask, well, okay, so now that we've fundamentally changed how practitioners are related to patients, it's no longer a payment directly from the patient or some kind of way in which they offer charity care for patients, but instead now we have a third party in this insurance scheme that has come in and changed the nature of this relationship. Is medicine still a profession? And under a substantive approach, it's almost impossible to answer that question without just assuming that they are or assuming that they're not. That is, if we use medicine as a baseline to define professions, or we use law as a baseline to define professions, and then those professions change over time, how do we know when they no longer count as a profession? And so a substantive approach can't answer that question in a way that isn't obviously arbitrary. Substantive approaches also face a second practical problem, and this is of greater concern for bioethicists and clinical ethicists, and that is, if you're using a substantive approach, how do you handle new professions that arise? That is, it may be that you're going to have an occupation that comes in and says, well, we're close, but we don't quite meet all of the same criteria that the existing professions do. How do we determine which criteria really matter and which criteria don't? And one way to look at this problem is to ask the question, whom do clinical ethicists serve? That is, who is their primary responsibility to? If you're looking at medicine and law, right, so it's the client or the patient. This is their primary responsibility. This is who they are responsible to care for. This is where their focus should be. But clinical ethicists have never really been in that role. Even almost 20 years ago, right, it was recognized that clinical ethicists fill a role that has multiple individuals to whom they have, or groups to whom they have responsibilities. And so what this means then is that we would then have to say, well, because they're not exactly like medicine and law, then they won't count as a profession. And so then it seems to be that the definition from a substantive approach would then preclude the possibility of new professions coming in unless they look exactly like the old professions. Of course, even the old professions don't look exactly like they did before, and we're not exactly sure how to accommodate that either. And so from my perspective, the substantive approaches are fundamentally flawed. That is, it's not going to be a particularly useful strategy to try and identify specific criteria that occupations have to meet in order to become a profession, to count as a profession. And so instead, I'm going to suggest a more formal approach to identifying what counts as a profession. And here I'm borrowing specifically from Michael Davis at the Illinois Institute of Technology in Chicago. He's written about professions and conflicts of interest for 35 years or so, but recently he's offered a different view of how we determine what counts as a profession. And instead of trying this sort of sociological substantive approach of Greenwood and Baha'i, he's offering a more formal approach. That is, rather than identifying specific criteria that have to be met in a checkbox kind of way, do they have this, 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 and this, and this, he sort of says, here's a general sort of approach we can look at and that we can then use to identify who counts as a profession, who doesn't. I put some emphasis on some key points in the quote, but basically the idea here is that if the members of an occupation, right, voluntarily choose to serve some moral ideal more than they're already required to, They're going beyond what is legally or regulatorily or in terms of licenses required to do. And they're saying there's something more that we're interested in trying to achieve, that we're aimed at achieving. That makes it then a profession. And so then you can see how this is formal, because other than just this general commitment to a moral ideal, there's no specific criteria. Do they have a code of ethics? It might matter, right? But only if that helps them identify what the moral ideal is. Do they have to have expert knowledge? Not necessarily, right? And so it just becomes a question of, is this occupation committed in this kind of way? Okay, so there are a couple of advantages to taking a formal approach. So why I think we should sort of endorse a formal approach to identifying what counts as a profession. It avoids the conceptual and practical problems of substantive approaches. So one reason to pick it is that you don't have a difficulty with the begging the question, because it doesn't assume what counts as a profession and what doesn't. It also doesn't have the practical problem of professions as they change over time, or new professions, because the simple question is, are they committed as a group to some moral ideal beyond what's required of them? And if they are, then they count. And so then we don't have to worry about if the profession has changing financial relationships in the background of its work, right? Or it even changes the client that it serves, or it has multiple clients to serve. That doesn't affect specifically whether or not it counts as a profession. Instead, what matters is, are they committed to some moral ideal? And so it can avoid these substantial difficulties for the substantive approaches. It also has an advantage because it makes professionalization a question of self-group determination. That is, they get to decide for themselves if we're a profession. So it doesn't become something that's determined from the outside, specifically you get to count and you don't. Are they intentionally, as a group, as a self-determining group, pursuing a particular ideal? And if they are, then Davis is going to say they're going to count as a profession. Okay, so there are a couple of reasons why the formal approach might be the one we want to adopt, but then that doesn't mean that there aren't difficulties for the formal approaches, and so I want to be clear about those, because it's not as though this is a panacea or just obvious this is the best thing and there's nothing to improve upon. So there are a couple of constitutional problems with a formal approach. So when you say that a group is self-determining to achieve some kind of moral ideal, how much of the group has to be aimed in that direction, right? And Davis can't really answer this. It's not clear that we could get an answer to this, because it's not clear how you would even know that individuals do try and serve that moral ideal. And so this leaves some ambiguity about what counts as the group self-identifying their moral ideal. And we'll see this more when we talk about specific codes of ethics in a little bit. But this produces some ambiguity about who counts as a profession or how we decide something counts as a profession. And then the other problem is, what do we do with rebellious professionals? So let us say that we have an occupation that self-identifies as a profession, aims at some moral ideal, and then you have individuals who work in that occupation who explicitly reject the ideals that are adopted by the whatever majority of the group, whatever percentage of the group we need to have. Where do we count those individuals? They're still working in that occupation, but they're not aiming at the moral ideal in the same way or at all. So do they still get to count as professionals or not? And this again creates a difficulty, because they're doing the same work in some sense, even though they lack the same commitment to a moral ideal. There's also a definitional problem with the formal approaches. That is, there's a difficulty in identifying professions, because somebody tells you, well, I'm a professional, right? So medicine is a profession, right? And so when they say that, what they're saying on the formal approach is, we have, as a group, committed ourselves to some moral ideal above and beyond what we're required to do. Okay, then we're going to have a necessary follow-up question for any occupation that claims to be a profession. What does it mean for this group to be a profession? That is, in a certain sense, to say that one is a profession is going to be then it's going to be a formal claim, but it's not going to have any content by itself. That is, if I'm to claim, well, I'm a college professor and I'm a professional, you would need to ask then, well, what does that mean, that a college professor is a professional? What does it mean that a physician is professional? Because on the formal approach, all that tells us is there is some moral ideal we're committed at. What that moral ideal is, what are the obligations that they're taking on as they try to pursue that moral ideal, remains undefined. And so as a result, the formal approach has the advantage of anybody, any group, any occupation can claim to be a profession so long as they commit to a moral ideal. But just the claim to be a profession in and of itself doesn't tell us anything about that group or what moral ideal it is committed to. Okay. So I'm sort of made the case here that we should be adopting a kind of formal approach to identifying what counts as a profession. That is an approach in which we simply say that occupations that commit themselves to a moral ideal are above what's required by law and regulation, are occupations that we should count as professionals. The question then is, well, how is it that we're going to distinguish professionals from non-professionals? That is, what does that mean the characteristic is? And specifically, that means that we're going to have some explicit articulation of responsibilities and commitments that go beyond the basic responsibilities of any occupation. So in order for it to be meaningful, I mean, I guess in a hollow sense, one could claim to be a profession without doing this. But if we don't have an explicit articulation of the responsibilities they're taking on, the commitments that they're aiming to pursue, then we don't know what it means for them to be a profession. And so if there's going to be any meaningful sense in which we say this group, that occupation is a profession, we're going to need some explicit articulations of responsibilities and commitments. Something that tells us what it is that they are aiming at, what they are taking on as their responsibility. And so it's here that we're going to see codes of ethics come into play. Because codes of ethics are a way for professions to identify what responsibilities they're taking on. They're saying this is what we are committed to as a group. These are the standards that we expect the members of our occupation to either follow, or these are the aspirations that we want them to try and achieve. And so what that means then is that we need to look and then see, okay, so then if that's the case, what does it mean for clinical ethicists? What does it mean for bioethicists? What does it mean for physicians and other medical practitioners to be a professional? Well, we need to look at their codes of ethics. And as I said, I'm going to start with the ASBH Code of Ethics for Healthcare Ethics Consultants. So I've just listed here briefly, if you're unfamiliar, the 7 obligations that are set out in the ASBH Code of Ethics from a couple of years ago. And they're relatively, I mean, they have the advantage of being relatively brief, and so they're not complicated, although there is supporting documentation that expounds on these, and I'll get into that a little bit. But it identifies, right, what they're saying their obligations are, right? So the obligation for the healthcare ethics consultant is to be competent, to preserve integrity, right? So here are what they're saying. These are the responsibilities of being a healthcare ethics consultant. This is what they're saying the responsibility is. These are the additional obligations they've taken on beyond what's required by any law or regulation. And so the question is, how well does this code do at defining for us these obligations? And so I'm going to walk through these in some detail, a little less detail for the AMA and ANA codes. But so the first one is to be competent. And I would suggest that the argument that the clinical healthcare ethics consultant, is specifically as the ASBH code is written, should be competent, is what I would call an empty obligation. And to demonstrate that, here's a quote from their expansion of the requirement to be competent. The healthcare ethics consultants should practice in a manner consistent with professional healthcare ethics consultant standards. Okay, so if we go back, right, the definition of what it means to be a profession that I'm arguing makes the most sense is that it's a formal commitment to something beyond what law and regulation require. So to say that a healthcare ethics consultant has to meet the professional healthcare ethics consultant standards means that they have to meet the obligations that healthcare ethics consultants have committed themselves to. And those standards are codified as best as they are within this very code of ethics. So then the responsibility is to meet the standards that this standard defines. And so you can see how this is internally circular. Well, what are you required to do? Well, I'm required to meet the standards. And what are the standards? Well, they're what I'm talking about right now. And so this one could use a bit more, what does it mean to be competent in this case? So we start off perhaps not on the strongest the strongest start for the ASBH code. And then there are a number of the obligations identified in the ASBH code that I would describe as every occupation obligations. That is, these are the obligations that any occupation would have if, that is, it doesn't go beyond what would be typically required of any employee anywhere. And to demonstrate that, I'm using a reductio ad absurdum argument. That is, I'm just going to take the obligations identified in the ASBH code and then substitute in barista and coffee company and see if they make sense. And if they do, then it seems like we're not really talking about something that's special to healthcare ethics consultants, but instead we're talking about something that counts for any occupation. So, right, preserve integrity was requirement number 2. Baristas should consistently act with integrity in the performance of their barista role. That seems to make sense, right? That doesn't seem to be adding anything to what a barista is supposed to do. It's not providing us with important information about their obligations. Baristas should anticipate and identify conflicts of interest and obligation and manage them appropriately. It's broad enough and vague enough that it seems, again, that the barista would should do this as well. So again, it's not clear how this adds to the obligations of a healthcare ethics consultant. Baristas should participate in the advancement of the coffee company, right? Again, this seems like an obligation that we would expect of the barista or any employee in any occupation. And then finally, when communicating in the public arena, baristas should clarify whether they act in their barista role and should communicate in a manner consistent with the norms and obligations of baristas. Right. So these are all just to demonstrate that each of these obligations are basically obligations that we would expect anyone to have. Right. They're not special to any particular role, and so we could plug in any kind of occupational role, and these obligations make sense as sort of assumed obligations of an individual within that role. And so what I'm trying to do by laying these out is demonstrate that in terms of identifying what the responsibilities of healthcare ethics consultants are, what moral ideal they're trying to achieve above and beyond what's required by law and regulation, it's not telling us much here. And so there's still 2 obligations that are identified in the ASBH code that may actually provide us with more substantial obligations. One of them is the respect privacy and maintain confidentiality. And that one, they say something that suggests that there may be a responsibility they have that goes beyond what's minimally required. But at the same time, it's not clear if this really goes beyond what's required by law and regulation. That is, by saying that they should divulge confidential information when it's necessary to provide significant benefits, share it with healthcare leaders and staff members, agents appointed in advance directive. Some of these things are legal requirements, right? They're not beyond what would be required anyway. And so then, again, all this may only be saying, healthcare ethics consulting should follow the rules of healthcare. And so again, we're not getting to obligations that go beyond what's minimally required. And then there's one that actually I think I would argue goes beyond other obligations, and that's that healthcare ethics consultants should promote just healthcare. This seems to be something that is not necessarily required. It is, healthcare ethics consultants should work with other healthcare professionals to reduce disparities, discriminations, and inequities when providing consultations. They should work against obvious injustice. I don't know that we would consider that to be something that's required of every occupation, but we might also suggest that that's something that we would expect a good citizen to do. And so I'm on the fence about if this actually adds anything. That is it really an acquired obligation? Is this something special for a healthcare ethics consultant to do, or is this something we would expect of any citizen? I think we might expect it of any citizen, but it's not something that every citizen is required to do. It's not something that's legally and regulatorily required. And so in this sense, it's the healthcare ethics consultant, by adopting this code, by adopting this obligation, is going above and beyond what's minimally required. And so in that sense, then it's more than what we automatically expect given the occupation. And so we have one obligation that we can identify clearly as fulfilling this formal requirement of some additional moral ideal, and that is to promote just healthcare. Okay, so this suggests, okay, so what does it mean to be a professional healthcare ethics consultant, right? So if we're going to say, well, we're going to be a professional healthcare ethics consultant, it's not exactly clear. Maybe it means to promote justice, right, to work against injustice. outside of that, and that in and of itself is relatively ambiguous and broad, but nonetheless that's okay. But outside of that, it's not exactly clear what it means for healthcare ethics consultants to be professionals. And so in this sense, then, that code of ethics would need to be amended, added to, etc., in order to give us some clearer idea of what it means when healthcare ethics consultants claim, I'm a professional. Because again, just to claim I'm a professional doesn't tell us much. What we need to know is what are the moral ideals that that profession is committed to, and that's the key question, and that's what we haven't gotten particularly good answers to here. Okay, so there's a couple of other codes that I want to at least briefly look at. Oh, I'm sorry. Next steps, more clearly defined obligations needed. Who will endorse it? I'm going to set that question aside until after we talk about the AMA and ANA codes. Okay. So I've just listed, and I'm not going to read through here, the AMA Code of Medical Ethics. So these are the primary principles. I mean, if you're not familiar, the AMA Code of Medical Ethics comes with a very thick book if you order the book, which has opinions which give much more detail about specific issues that medical practitioners may encounter. But here's a statement of the basic obligations that structure the rest of the opinions that are produced by the Council of Ethical and Judicial Affairs, right? And these are obligations that the AMA membership has endorsed, right, as part of the responsibilities of medical practitioners. And if, you know, as you're probably aware, this code has been in development for more than 150 years, and so this is a lot more refined than the ASBH Code of Ethics, which is relatively new, and so you would expect it to be perhaps more robust, perhaps a little clearer, because it's had more time to develop. That said, of the 9 sort of obligations that are identified here, I can only pick out these 4 as being obligations that go beyond what we would typically expect of physicians. That is, that provide indication of the responsibilities that physicians have beyond what we would just simply expect of individuals in any occupation. And so this is kind of a little bit surprising, right? I mean, if we go back, I'm going to, if I can, I'm going to go back a slide. So if we look at number 2, right, physicians shall uphold the standards of professionalism, be honest in all professional interactions, and strive to report physicians of deficient in character and competence or engaging in fraud. Actually, you know what? I think there was a mistake. So actually, number 1 and number 2 should be switched on this slide. That was my mistake. Number 2 actually is one that I think that they actually do have as a new obligation. Whereas if we look at number 1, we can see that a physician shall be dedicated to providing competent medical care with compassion and respect for human dignity and rights. That's not telling us much other than they're going to be competent at their job. And then, you know, generally compassionate and respecting human rights, but again, that would we expect as a normal obligation. If we look at number 3, a physician shall respect the law, it's standard, also recognize responsibility of those requirements which are contrary to the best interest of the patient, right? And actually, you know what, now that I look at it, I think these may have just been inverted. Yeah, so these get inverted. So it's actually the faded ones that are the ones that I was focusing on, and the darker ones are the ones that I was hoping to fade out. So number 1, number 4, number 5, and number 6, we'll look at these, are all responsibilities that I think physicians have just by nature of having any occupation, right? Number 4, follow the law, right? Number 5, be competent at your job, right? And follow the responsibilities regarding coordination and informed consent. And then number 6 is actually not about their responsibilities to others, but actually about a freedom that they have themselves. So if we go back a slide and look at number 2, 3, 7, 8, and 9, right, here we have some obligations that physicians have that aren't obviously required by law or regulation. And I've pulled these out in the next slides, right? What does it mean to be a professional physician? And I'm going to sort of summarize those 5. One is that obligation number 2 requires them to report those of deficient character. which is a substantial obligation, right? It goes well beyond what's necessarily required of individuals in other occupations or just in general, but it's a requirement to report those of deficient character. Some could be concerned that deficiency of character would be hard to define, but nonetheless, that's clearly a stated obligation. Number two, work to change laws that are detrimental to patient interests. Right, so this requires them to be a political advocate in some way, and that's clearly beyond what we would expect of typical occupational responsibilities. Number three, recognized responsibility to community health. Right, and here what we're talking about is the recognized responsibility to community health is that they have a responsibility that goes beyond the patient in front of them, beyond what the work that they're doing on a day-to-day basis. And so again, this is a new obligation, a more robust obligation than we would typically expect from an occupation. Number four, treat patient interest as paramount, and that means even above their own interests. Right, and so here we can see that the classic physician-patient relationship represented in an obligation, right? They're supposed to be a fiduciary, they're supposed to be somebody who cares for the patient first and most. And then finally, support access to medical care for all is the ninth principle within their code of ethics. And again, that's not something that would be required to act as a physician. And so if we're talking about, well, what does it mean for a physician to be a professional, these are the 5 obligations that the AMA Code of Ethics identifies that are obligations that go beyond what's required of them simply by being licensed as a legal physician. Right? These are the responsibilities. And what's interesting to me about this list is that it's maybe number 3, responsibility to community health, but certainly number 4 that we would think of as the classic obligations of physicians. Right? Reporting those of deficient character, working to change laws, and support access to medical care for all. While we may think of those as good characteristics for a physician to have, we wouldn't think of them as the required, right, commitments of a physician in order to count as a professional. And so this then, at least raises some questions about, right, how we even conceive of these professions. That is, why it's important to look at codes of ethics to identify what it is they mean to themselves when they identify themselves as professionals. Okay, so I want to briefly look, and this is going to be very brief because I'm far less familiar with the ANA Code of Ethics, but I was struck by it when I looked it up because as far as I can tell, every one of these includes at least some nugget of responsibility that goes beyond what would be minimally required of someone being a nurse, right? So a nurse practices with compassion and respect for inherent dignity, worth, and unique attributes of every person. That one may be a little bit broad, but the responsibility to act with compassion, so you can't simply be doing your job, it's a little bit more. The nurse's primary commitment is to the patient. This echoes the responsibility of physicians. The patient's interest is paramount. The nurse promotes, advocates for, and protects the rights, health, and safety of the patient, again, doing beyond simply what the technical responsibilities of the job are. The nurse has authority, accountability, and responsibility for nursing practice, takes action consistent with the obligation to promote health and to provide optimal care. And so I'm not going to walk through all of these, but one of the things I was struck by is how each of these seems to actually provide some grounding for an obligation that goes beyond what would be minimally required to do the work of the occupation. And so this is perhaps of the 3 that I'm looking at, right, the Code of Ethics that has the most robustly defined sense of obligation that it identifies. So both of these, right, I'm suggesting are more well-defined, provide more information about what it means to be a professional nurse or a professional physician, but there are still questions about both of them. So the 2 questions that I want to focus on are, 1, who endorses these? That is, remember that part of what made the formal criteria for professional work is that the individuals within an occupation intentionally and voluntarily endorsed some kind of moral ideal that went beyond what they were required to do. How many of physicians and nurses actually endorse the Code of Ethics for the American Medical Association or the American Nursing Association? And this is a complicated question to try and answer. I mean, one heuristic you might use is, what is their membership? So the AMA has a membership that is always recognized as quite low, less than 30%. licensed physicians in the United States are members of the American Medical Association. And so that in and of itself would raise some red flags, but simply because a physician is not a member of the AMA doesn't mean they wouldn't endorse the AMA Code of Ethics. But at the same time, even if somebody is a member of the AMA, doesn't mean they would endorse the American Medical Association Code of Ethics. So, as I pointed out when we went over the formal approaches to professionalism, how high a percentage do you need to actually endorse the ideal for it to count as the ideal for a profession? And we don't even know how many of the physicians and nurses actually endorse these codes of ethics. And so that means that does this then count as a moral ideal that they as an occupation have endorsed, or is it some kind of superfluous structure? I mean, so one thing that's interesting about the AMA code, at least, that I learned when I was a senior fellow there, is that the AMA sells the codes of ethics with their associated opinions. It's a relatively thick book. And the people who buy the most of the codes of ethics with the related opinions, at least at that time, but I'm no reason to think it's changed, is actually lawyers and not physicians. So question of who all endorses these. And then we're also going to run into this problem of what do we do with physicians and nurses who explicitly ignore the code of ethics that the AMA and the ANA have set out. That is, how are we supposed to handle them? Are we going to say that they are professionals, that they're not professionals? Do they raise questions about the very nature of the profession at all? And I don't have an easy answer for this question because it seems like we don't want to preclude the possibility of an occupation claiming to be a profession, but we need some way to handle the problem of individuals who choose to explicitly reject the moral ideal that other members of the occupation have adopted. And so we still have these difficulties for the American Medical Association, the American Nursing Association. Okay. One last quote as I wrap up, I guess just a couple of minutes early. This is from a presentation that John Ladd did in the 1970s, in which he was critical of codes of ethics in general. So I've sort of hung the hat of professionalism on codes of ethics, but I want to then turn at the end here and reflect back on the use of codes of ethics in this way. As you can see by the title at the bottom, he calls codes of ethics an intellectual and moral confusion, so not a positive view of them. His view is that they're largely public relations. That is that codes of ethics turn out to be something that doesn't help professionals in meaningful ways and actually is really just about public relations, and hence this is where this quote comes from. The code is supposed to communicate to the general public the idea that the members of the profession considered are service-oriented, that the interests of the client are always given first place over the interests of the professional himself. Because they have a code, they may be expected to be trustworthy. And so this suggests that this is sort of, I've laid out a plan, and this is sort of, burning my own plan at the end here, that in fact the codes of ethics may not actually serve the purpose that I'm hoping they would. So if we're going to talk about professions, the formal criteria and the formal approach is the way to go. And the formal approach requires them then to identify obligations that they are committed to that go beyond what they're legally and in terms of licensing requirements, what they're required to do. And the best look into what those ideals, what those obligations might be, is the codes of ethics that these organizations adopt. And yet, one might wonder, do codes of ethics actually serve that purpose? Or are they really more of a statement of public relations, a statement to indicate to others that you can trust this occupation because they have a code of ethics? And so with that, I'll wrap up and sort of say that I have not provided you a clear answer to the question of what it means to be a professional in bioethics or in medical practice, but I've provided, I hope, at least some way to begin to look at these problems so that we can identify what responsibilities we think that clinical ethicists and other bioethicists might have as they continue on a march towards professionalization, and also be critical of the responsibilities that we've connected to the professionalization of physicians and other medical practitioners.
Thank you, Professor Schwab, for that fascinating discussion on professionalism. I've already received a few questions, but at this point I'd like to open the floor for additional questions. As before, you can ask a question by typing it into the text box located on the lower left-hand side of your screen. I will ask the speaker the questions so that we capture these questions on the recording. While we wait for you to type in your questions and before I begin asking the questions I've already received, I just want to inform you of our next upcoming webinar. Our webinars are held every second Wednesday of the month from noon to 1 p.m. Eastern Time. Thus, our next webinar will be on Wednesday, November 8th at noon Eastern Standard Time. For those of you outside the United States, please note that we will be switching off of daylight savings time to standard time prior to the next webinar, so it will be 1 hour later for you. Now, that webinar will likely be on topics related to public health interventions and will be presented by my colleague from the University of Latvia, Signe Mazinska, who is both an instructor in our Central and Eastern European Advanced Certificate Program as well as an alumna of this program. Now that said, Professor Schwab, I have a number of questions that have already been submitted. And the first was regarding your comment about the formal approach serving as a moral idea beyond what law, market morality, and public opinion would require. And can you just sort of distinguish a little more specifically about what you mean by moral idea versus morality?
Yeah, so the idea, so what Davis is getting at, it's a good question, by moral ideal, is that there is something that they're committed to or some set of obligations that they're committed to that aren't simply the minimum requirements of what it means to be a moral individual or to follow basic morality. So morality is a way we figure out what we ought to do, and we can think of it as there are certain moral obligations that every individual has simply by being an individual. And then there are certain obligations that every individual would have when they take on a particular obligation, right? So for example, to keep with the barista story, one of the obligations they would have is don't steal from the place that you're working at. And that's an obligation that they have. Whether or not they commit themselves personally to it, that's an obligation we see as part of that relationship that's built into their responsibilities. The moral ideal of an occupation then would be something that goes beyond that. And so it would be something where there's some goal that they have that has some kind of obligations associated with it, hence it's a moral ideal, that goes beyond what's minimally required in a occupation or employee-employer relationship or within the occupations that one has in the private sector. And so, I mean, one way to think of it most broadly in terms of the AMA code, for example, would be that there's a commitment to the moral ideal of improving patient health. Maybe that's the way they want to describe it in the most broadest terms. And then they're going to define specific obligations beyond that. And so what they would say is, the moral ideal we're committed to is we ought to improve patient health. And that goes beyond simply like treating diseases when people show up or providing preventative care when people ask for it, right? So there are things that they could do that would improve patient health that would be like minimal responsibilities of filling the role of physician. But then when we're talking about a moral ideal, then there are additional responsibilities that they take on that go even further. And so you can see that in the responsibility to advocate for changes in law that would improve the patient's care, right? That's one of their responsibilities. That goes beyond simply handling the patients as they show up to the clinic.
Great. Thank you, Professor Schwab. So our next question is about professionalism in professions that are clearly defined and recognized. So if we have a profession that is clearly defined and recognized, does it then automatically make all who serve in that profession a, quote, professional, unquote? Can there be non-professionals or unprofessionals even who exist within a profession?
Yeah, and so this gets back to that question, again, a good question, about rebellious professionals. And so in a very narrow sense, obviously there can be unprofessional members within a recognized profession, and those are the ones who willfully violate the professional standards or even the legal and licensing standards of that profession. So, and this always makes the news periodically. I mean, I should say always makes the news. This makes the news rounds periodically when there's a physician, for example, who has violated basic standards of practice, right? And so then they've obviously failed to meet the legal and licensing requirements, so they're obviously not going to count as a professional. The more complicated question becomes, what if they meet all the licensing and legal requirements of practicing medicine, but fail to make the patient's interest paramount? Right? Then do they count as a profession? And I honestly don't have an easy answer to that question, because it seems to me that they wouldn't, because they're not then following the ideal that the group has committed itself to. But then at the same time, what do we call them? So would we then we can end up in this very strange situation where we have complicated hierarchies of licensed physicians versus professional physicians, or licensed clinical ethicists rather than professional clinical ethicists. And so then it becomes a complicated sort of decision about, do we want to draw distinctions so that we characterize different members of the same occupation differently based on their relationship to the ideal, or do we just want to focus on what the ideal is and whether or not the occupation in general is committed to it?
Great. Thank you, Professor Schwab. So our next question sort of builds off of that and also touches upon some of the points you raised when talking about the AMA and ANA codes of ethics, and particularly the fact that not all members of the medical or nursing profession necessarily belong to these organizations. So who does these organizations presume to speak for? Who does the AMA speak for, the ANA speak for, the ASBH speak for, and what sort of does that impose upon members of a profession who don't belong to a particular professional organization?
Yeah, so so in the narrowest sense, they can only speak for the members of their organization. Okay, so I mean in a sort of straightforward sense, but it's obviously more complicated than that, because part of the reason that, I mentioned the factoid from my time at the AMA, that lawyers ordered more versions of the Code of Ethics than anyone else, is because the AMA code is then used when evaluating physicians whether or not they're members. Now, the disciplinary choices that the AMA, the ASBH, or the ANA can make are contingent on membership. But I think that their goal is to speak for the broader profession. That is, their aim is to provide sort of an explanation of what it means to be a physician in the United States, what it means to be a physician, what it means to be a nurse in the United States, and what it means to be a clinical ethicist in the United States. And so I think that's the goal that they have, and that's what they aim to achieve. Whether or not they successfully are able to do that is a separate question, and of course that's limited by the inputs that they receive. That is, who it is that's providing the insight into what should count or what they believe should count as their obligations. And so again, the clearest answer is they only represent their membership, but their aim is to represent more than that.
Great. Thank you, Professor Schwab. I have one more question for you, but if any of the participants in the webinar have additional questions for Professor Schwab, please type them into the chat window now. And the question I have for you, Abe, relates to this issue of when a physician can't meet their professional obligations, not for reasons of their own actions or decision-making, but because of externalities. So, for example, when resource allocation in medical practice means that a physician can't follow what she believes is her appropriate professional duties, but instead must refuse or cannot provide care to patients.
Yeah, so for this I would borrow the architecture of moral philosophy more generally. So when we think of obligations, or if we think of things that we have an obligation to do or things that we're prohibited from doing, the way we think of these rules or these obligations is that they're specific and they provide guidance, but they aren't very often absolute. And so if one is precluded from doing something we claim that they ought to do, then we would typically describe that inability to do it as excusing the inability to follow the rule. I mean, it actually goes back to an axiom of moral philosophy that's more foundational than that, which is that you can't have a responsibility to do something that you can't do. That is, you cannot be morally obligated to do something that is beyond your control. And so there's no sense in which we would say that they have in some way demonstrated a moral failing because they were unable to do something if that was not within their control. And so ultimately we would describe this then as if it was a commitment of the moral ideal of the profession, then you would describe this inability to meet that obligation as excusable given the circumstances, right? And so you would look at the situation and say, listen, it would still have been better if they had met the obligation. That still would have been the preferable thing to do, but given the circumstances, we're saying that they're morally excused from meeting that obligation because they could not have done otherwise. And so we can't hold them responsible for something that they could not control.
Great. Thank you, Professor Schwab. So we have another question. It's an interesting hypothetical question, and it relates to how professions, particularly the medical profession, might change with changing economic models. So currently, it's fairly common for physicians to discuss cases amongst themselves without sort of any expectation of reimbursement. You call up your friend, and you ask them to provide you some advice on a particularly tricky case. Now, in other professions, it's a lot more common for those individuals to actually be paid or remunerated in some way for these sorts of case discussions. And we're seeing a shift, particularly in things like the medical literature, which is one of the key sources of access to medical knowledge for physicians in terms of paid access, particularly in lower and middle income regions of the world. So how do you see some of these changes in economic models and the changes in way physicians are paid affecting models of medical professionalism?
That's a great question. So, I mean, I think that one thing that we might say, if we were to be particularly critical of the AMA code, and maybe even the ANA code, but I'd have to look more closely, is that conflicts of interest that are produced in the business of medical practice are becoming a far more substantial problem. And so the example I like to use here is from the HMA that was running in Florida. They were running a number of hospitals in Florida, and in one of the hospitals, in the emergency room, in the doctor's lounge near the emergency room, they had a whiteboard on which they had every physician's name, every ER physician on duty's name, and the names were color coded. If they had admitted over 50% of patients who were over 65, then they were color-coded green. If they had admitted between 40 and 50% of patients over 65, then they were color-coded yellow. And if they were had admitted under 40%, they were color-coded red. Now, this is the allegations. I don't know if these have been proven in court, but this is the allegation, is that this whiteboard existed in this hospital. And so what this clearly was an attempt to do was to provide a kind of subtle social pressure on emergency room physicians to admit as many patients as possible over the age of 65. And of course, this would violate what we want the physician to be. This kind of pressure would push against what we want the physician to do. We want the physician to determine whether or not somebody should be admitted to the hospital based upon their medical condition, not based upon the number of patients they've admitted over the last week. And so in this sense, then it puts a pressure on physicians to act in ways that we would not want them to not act according simply to what's in the patient's interest. At the same time, the difficulty with the situation is it's not clear what we would say that the company did wrong. That is, they were providing a kind of social pressure to achieve an outcome that would improve their profitability. That is, the Medicare patients would provide a source of economic revenue, and so then they were putting the kind of social pressure to achieve that goal. So they were putting the kind of social pressure that would lead to what we would consider an unethical outcome, even though it's not clear that they themselves were doing something that's obviously unethical. I mean, I think you can make the argument that it is, but it is not obviously, it's not straightforwardly unethical for them to do that. It doesn't violate obvious moral rules that we're aware of. And so this creates a difficulty for physicians because that's just one example. There are physicians get reimbursements based on referring in-group versus out-of-group. And so the conflict of interest scenario with the way that medicine is being handled financially is become complicated and has become something that more attention needs to be paid to. And so one of the things that I would suggest this does is it may create new obligations for physicians to sort of like say, okay, so our commitment is to the health of the patient in general. And given our current circumstance, one of the things that means is we need to be working against conflict of interest scenarios in our new complicated financial reimbursement schemes. And so then that's going to require a more what am I looking for here? A more motivated approach to handling conflicts of interest than was necessary even 25 years ago. And so as a result of these changing circumstances, the specific obligations the profession has will shift in order to continue achieving the moral ideal they've committed to.
Great. Thank you, Professor Schwab. Unfortunately, it's now 1 o'clock and we are out of time. Jan just submitted one last question. I don't know, Professor Schwab, if you can hang on an additional minute or two to answer it.
Sure.
Okay, so he was asking about the pressure of new techniques in medicine. If one is old-fashioned and does not want to accept new techniques like minimally invasive surgery just because he is not practicing them, is it morally excusable?
So this is from the practitioner perspective, I take it. And so then the question is what does it mean to be, what are the responsibilities for physicians as professionals to adopt new techniques? And that's going to be a case-by-case kind of question, in part because it's going to depend upon what the positive health outcomes for the patient are that result from the new technique. If it's so because there's the learning, so there's a learning curve question. So as the practitioner looks at a new technique, it's not something they've used, and so when they first do it, they're more likely to make mistakes, right? And so when you're talking about techniques, often we're referring to things like surgery, and this actually involves a certain kind of technical skill, so it's more complicated than simply writing a prescription. And so as a result, there turns out to be a learning curve, and so the first few, they're more likely to make mistakes than they are as they get more and more practice. And so that creates a certain kind of risk associated with that particular practitioner carrying out that particular procedure. And so then the question is, how do we balance that increased risk associated with a new technique with the promise of better outcomes as a result of the new technique? And so then this would be a case-by-case basis in which you would evaluate what is the expected benefit of the new technique for patients, and how does that balance against the time frame, how long it will take, and the risk associated with the adopting of a new technique. And so I don't think there's going to be a really straightforward and easy answer there. I think that if the new technique has substantial improvements, then they're going to have a responsibility to learn it. If their practice is going to be around for more than another year or two, but if their practice is, and so then they're going to have that responsibility. But if the new technique offers minimal improvements but has some other advantage, say it saves the hospital money, then the responsibility becomes a different one because it's not about the patient's interest or the patient's health so much as it is about something else.
Okay, so just to confirm, so we're talking about new techniques, but those that are validated and confirmed, and the difference would really be about whether or not it's a substantial improvement for patients, as well as the rationale behind the use of that, and the physician's sort of practice in terms of longevity, correct?
Yeah, no, that's right. Well, and surgery is really complicated, right? Because you're not doing research in the same kind of way, and the use of new techniques is more complicated because, again, it's not as straightforward as other types of interventions because of the technical skill, the actual use of the individual's fingers, hands, etc. They actually have to do the activity. That actually makes it a far more complicated thing to introduce new techniques than in other areas of medicine. And so that is worthy of sort of like a whole conversation in and of itself: surgical innovation versus surgical research, and when we should adopt a new technique.
Great. Thank you, Professor Schwab. So unfortunately, we are over time, and so if you have any other additional questions or comments, you can feel free to send them to me directly via email, and I will share them with Professor Schwab, so hopefully he'll be able to answer them for you. I'd just like to close by thanking our speaker, Professor Schwab, and I'd also like to thank you as participants for joining us for this month's webinar. A link to the video recording of this talk will be posted later in the week. Thank you again for joining us, and I look forward to seeing you all at our next webinar on Wednesday, November 8th. Goodbye.